incredibly high-stakes strategy game.
Oh, absolutely. It's a game of logic.
We're looking at antimicrobial selection. We've got this source, chapter 35, and it reads less like a medical text and more like, I don't know, a manual for 4D chess.
It really is. I think, the general public kind of has this vending machine model of medicine.
Right.
You have a sore throat, you put in your copay, a pill comes out, you get better. It feels very transactional.
Yeah, simple cause and effect.
But when you actually peel back the layers of how an infectious disease specialist thinks, it's warfare, it's constant logic puzzles, and you're playing with incomplete information most of the time.
That's the vibe I got immediately. It's not just kill the bug. It's, okay, first, identify the enemy in this fog of war, then choose the weapon that won't blow up the hostage, and on top of that, make sure you don't create some super monster that destroys the world in 10 years.
Exactly. You are balancing three competing interests constantly. Efficacy. Will this actually kill the bacteria? Safety. Is this going to hurt or even kill the patient? And then there's stewardship. Will using this drug today make it useless for everybody else tomorrow?
So that's our mission today. We're going to unpack this whole systematic approach. We're going to walk through the mind of a doctor from that first moment a patient spikes a fever, through that fog of war guessing phase, all the way to the sniper shot of definitive therapy.
Right.
But before we even get to the drugs, the source material forces us to stop and ask a question that seems almost basic. Is this actually an infection?
It sounds so simple, but it is the most critical first step. We call it confirming the enemy. And this brings us right to what we can call the fever trap.
I found this part fascinating because if you asked 100 people, I bet 99 would say, if I have a fever, I have an infection.
Of course. Heat equals bug. It's intuitive.
But the text says,
right.
Well, not so fast.
Exactly. I mean, a fever technically is just a controlled elevation of body temperature above, say, 37 Celsius or 98.6 Fahrenheit. It's just a non-specific alarm bell. It tells you something is wrong, but it doesn't tell you what is wrong.
And the source specifically highlights this concept of drug-induced fever.
Which is the ultimate irony, isn't it?
It is. You're in the hospital to get better, you're taking a drug to help, and the drug itself is what's making you sick.
And it happens much more often than people realize. I mean, picture the scenario. A patient's been on an antibiotic for a week. They seem to be getting better, but now suddenly their fever spikes again.
The knee-jerk reaction would be, oh no, the infection is back, double the dose.
That's the rookie move, exactly. We need stronger antibiotics, this isn't working. But if you do that, and the fever is actually caused by the drug,
you're just pouring gasoline on the fire.
You're literally increasing the dose of the very thing causing the problem. The text is very clear. A drug-induced fever will persist as long as the drug is given, and it vanishes, usually pretty quickly, when you stop. So the strategic move isn't to attack harder, it's to pause and retreat.
Okay, so fever isn't the smoking gun, it's just a generic siren. So the next step is to look deeper, to look at the army, the white blood cells. The source calls this leukocytosis.
Right, an elevated white blood cell count. Normal is somewhere in the range of 4,000 to 10,000 cells per cubic millimeter. So if that number suddenly jumps to, say, 15,000 or 20,000, you know the body is mobilizing for a fight.
But the raw number isn't the whole story. You have to look at the composition of that army.
Exactly. This is where you get into that phrase that I'm sure you've heard on medical dramas.
The left shift. Yeah, I've always heard it, never really understood it. It sounds like a dance move or something.
It does, but the analogy in the text is actually perfect. Think of your bone marrow as the military barracks or boot camp. It's where your white blood cells, specifically the neutrophils, which are your main foot soldiers against bacteria, are trained and stored.
Okay.
Now, in a normal, manageable infection, the marrow sends out the veterans. The seasoned troops, we call these segmented neutrophils. They're fully mature, fully armed, ready to go.
But if the invasion is massive...
If the war is going badly and the veterans are getting wiped out on the front lines, the bone marrow starts to panic. It runs out of troops that are ready.
So it starts drafting the recruits.
It starts sending out the cells that aren't even finished with their training yet. These are called band neutrophils, the immature forms.
So when a doctor sees a left shift on a blood report with a high percentage of these bands, they're not just seeing a number, they're seeing a sign of desperation. The body is literally saying, we are throwing everything we have at this, even the kids who just got here.
Precisely. It implies a really acute, severe bacterial demand. And this helps with the differential diagnosis, figuring out who the enemy is. If you see high neutrophils in that left shift, you are almost certainly fighting bacteria.
But what if you see a different profile? The text mentions relative lymphocytosis.
Right, and if you see that a high lymphocyte count, you need to pivot your strategy completely because high lymphocytes don't usually point to bacteria.
They handle different enemies.
Totally different enemies. They usually point to viral infections, fungal infections, or even tuberculosis. And if you throw standard antibiotics at a virus, well, you're doing absolutely nothing except causing side effects and driving resistance. You're bringing a gun to a ghost fight.
There was one line in this section about white blood cells that was actually kind of terrifying. We associate a high count with infection, but the source mentions a paradox called neutropenia.
Ah, yes. That is the nightmare scenario.
Why is a low white count worse than a high one? It seems counterintuitive.
Because a high count means the body is putting up a fight. It's trying. A low count neutropenia during a severe infection means the body is losing. It means the bone marrow is completely overwhelmed or suppressed or just empty. The barracks are vacant.
So the production line is collapsed.
It's collapsed.
Mm.
If you have a patient who is in septic shock with a raging fever, but their white blood cell count is plummeting, that is a very, very poor prognostic sign. The defenses have crumbled.
Okay, so we've checked the fever, we've assessed the troops, we have a suspicion. Now we move on to the physical signs.
Yeah.
Pain, swelling, redness, the classic stuff.
The stuff everyone recognizes.
But the text makes this crucial distinction about what it calls deep-seated infections.
Right, and this is important. If you have an infection on your skin, cellulitis, the smoke signals are obvious. It's red, it's hot, it's swollen, you can see it.
Sure.
But what if the infection is in the brain, like meningitis, or deep in the lung, in pneumonia, or on a heart valve? You can't see the redness from the outside.
You can't just crack open the chest to take a look.
So you have to rely on fluids. You have to sample the environment. This is why we do a spinal tap to get cerebrospinal fluid for meningitis, or we collect sputum for pneumonia. We are looking for those white blood cells, those soldiers, in places they should never be.
Finding neutrophils in the spinal fluid is like finding soldiers in a public library.
Exactly. It tells you there is a battle happening right there, even if you can't see the flames.
This leads us perfectly into the next phase, the CSI, part identification of the pathogen. And the source has a golden rule here that seems incredibly rigid. Sample before you treat.
It is rigid, and for a very, very good reason. And this is a constant battle in the hospital. You have a very sick patient. Your instinct is to help them immediately.
Of course. You want to give the drug now.
But if you give that antibiotic before you get the blood culture or the spinal fluid, you might just sabotage the entire case.
Because the antibiotics are just too good at their job.
In a way, yes. Antibiotics can sterilize a culture, sometimes in minutes. Think of the antibiotic as a cleaning crew with bleach. If you send them into a crime scene before the forensics team gets there,
You're wiping away all the fingerprints?
you're destroying the evidence, you'll get a false negative. The lab calls back and says, hey, we didn't grow anything, and you might assume the patient is fine. But really, the bacteria are just suppressed, hiding in the shadows.
And now you're flying blind.
Totally blind. You don't know who the enemy is, so you can't pick the right weapon. You're forced to keep using these broad-spectrum shotgun drugs, which are more toxic and drive more resistance, all because you didn't wait 20 minutes to get a sample first.
So speaking of samples, we have to talk about the red herring, the contamination problem. The text talks about finding bacteria in the blood bacteremia, which sounds absolutely terrifying.
It is.
But then it says, hang on, is it coagulus negative staphylococcus?
Ah, yes. This is a classic trap for new doctors, for interns. You have to remember, we are not sterile beings. Our skin is a zoo. It is covered in bacteria. Staph epidermidis, diphtheroids. They just live there. They're our neighbors.
So when you stick a needle through the skin to draw blood,
No matter how well you clean the skin, sometimes that needle drags a tiny piece of skin and a few hundred of those neighbor bacteria right into the vial.
little hitchhiker.
Exactly. So 2 days later, the lab alarm goes off. Positive blood culture. Panic sets in. Everyone wants to start the big guns like vancomycin, but you have to take a breath and look at the type of bacteria.
Right.
If it's Staph aureus, that's a true emergency. That's a killer. But if it's coagulus negative staph and it only grew in 1 out of 4 bottles and the patient is sitting up in bed eating a sandwich and feeling fine,
It's just the neighbor who fell in the pool by accident.
it's contamination. It's noise, not signal. And if you treat that as a deadly blood infection, you're exposing that patient to weeks of IV drugs, kidney risk, huge costs, all for a clumsy needle stick. You have to have the confidence to say, this is not the enemy.
Okay, so let's say we've done all that. We suspect a real infection. We've carefully taken our samples. We've sent them to the lab. But now we have a time problem. The lab needs 24, 48 hours to grow the bug. We can't just let the patient get sicker while we wait.
And this is where we make our opening gambit. This is what we call empiric therapy.
The fog of war phase.
It's the educated guess. We can't see the enemy yet, so we have to fire based on probability. We ask ourselves 3 questions. Where is the infection? What bugs usually live and cause trouble there? And how sick is the patient right now?
So if it looks like pneumonia, a lung infection, you treat for the common lung bugs. If it's a urinary infection, you treat for bladder bugs.
Exactly. You start with a broad shotgun approach to make sure you cover the most likely culprits. In this phase, you really don't want to miss.
And then 2 days later, the lab calls back. We got him. It's Pseudomonas aeruginosa. And now we switch tactics.
Now we switch to definitive therapy. That's the pivot. You put the shotgun away and you take out the sniper rifle. You narrow your spectrum to the safest, most effective drug for that specific bug. This reduces side effects and critically reduces the pressure for resistance.
I want to dig into this menu of options from table 35 to 2 in the source. This is where the strategy gets really granular. It felt like looking at, I don't know, a sports bracket or a Pokemon matchup chart.
It's very much like that.
Let's start with the gram-positive Kochi. We have the Enterococcus siblings.
Faecalis and Faecium.
They sound like a vaudeville act, but the text makes it clear they are not the same.
Not at all. Enterococcus faecalis is the, let's say, good sibling. It's more predictable, usually plays by the rules, and is susceptible to a standard drug like ampicillin. It's easier to handle.
But Enterococcus faecium.
Faecium is the problem child, the black sheep of the family. It has developed resistance to many of our standard weapons, often including ampicillin and even vancomycin.
So if you identify faecium, your whole playbook changes.
It goes right out the window. You often have to bring out the heavy hitters like linezolid or daptomycin. These are expensive, powerful drugs with more side effects, and we try to save them only for when they're absolutely necessary.
Then we have the celebrity of the bacterial world, MRSA, methicillin-resistant staph aureus. The text makes a big distinction between hospital-acquired and community-acquired. Why does it matter where you caught it?
It changes the bug's armor. Think about it. Bacteria that live in a hospital are constantly being exposed to disinfectants, to hand sanitizer, to all sorts of antibiotics. They are the Navy SEALs of the bacterial world.
They're battle-hardened.
Exactly. Hospital-acquired MRSA is tough. To kill it, you almost always need to use vancomycin, an IV drug that requires careful monitoring.
But community-acquired is different.
That's the strain you might pick up at the gym or from a shared towel in a locker room. It's genetically a bit different. It hasn't seen the inside of an ICU. So surprisingly, it's often still susceptible to older oral drugs, things like clindamycin, doxycycline, or even Bactrim.
And that's a huge quality of life difference for the patient, taking a pill at home versus being chained to an IV pole in a hospital bed.
Massive. Which is why taking a good patient history, just asking where have you been recently, is a key part of the strategy.
Let's flip over to the gram-negatives. These all sound like villains from a sci-fi movie, especially Pseudomonas aeruginosa. The text treats this bug with a lot of fear.
I would say deep respect more than fear. Pseudomonas is the ultimate opportunist. It can live in water, on hospital equipment, anywhere. And it has this incredibly complex defense system. It has a double cell wall, and it has pumps that can literally push antibiotics out before they can even work.
And the text says for a serious Pseudomonas infection, you rarely trust just one drug. You use combinations, like cefepime plus an aminoglycoside.
That's the double coverage strategy. You have to double team it, essentially. Because Pseudomonas is a fast learner. If you hit it with just one drug and you don't kill it completely, it can mutate and become resistant in the middle of therapy. By hitting it with 2 different mechanisms of action at the same time, you make sure you get the kill before it can adapt.
Now, on the other end of the gram-negative spectrum, we have E. coli. I usually just think of that as, a food poisoning bug or maybe a UTI.
And it is the #1 cause of urinary tract infections by far. For a simple UTI, the strategy is usually simple too. A drug like nitrofurantoin. It's great, it concentrates in the bladder, does its job, and you're done.
But the text points out that the same bug, E. coli, can also cause something as severe as meningitis.
Yes, same bug, completely different location. And this is where the logic puzzle gets really tricky. Nitrofurantoin works in the bladder because it gets filtered by the kidneys and concentrates in the urine. But it cannot get into the brain. It physically cannot cross the blood-brain barrier.
So if you use the standard UTI drug for meningitis, the patient dies.
The patient dies. Even though the lab report will say E. coli is susceptible to nitrofurantoin, you can't use it. You need a drug that can breach the brain's fortress, something like ceftriaxone. This is why you can never just match bug to drug. It has to be bug plus the site of infection matched to the drug.
That is the perfect transition to the next section, the terrain. We've talked about the enemy, but now we have to talk about the battlefield, the patient. The source calls these host factors.
Right. You can't treat the infection in a vacuum. The patient isn't a petri dish. And the most obvious variable is allergies.
The penicillin allergy is the big one, I assume.
It's a major pivot point because it doesn't just remove penicillin from your arsenal. You have to be cautious with a whole class of related drugs, the cephalosporins, because they're chemical cousins. If a patient has a severe anaphylactic reaction to penicillin, there's a small but real chance they could react to those too. You have to pivot to entirely different drug classes.
And then there's age and condition. I saw these little footnotes all over the drug chart. Footnote A, not for use in pregnant patients or children.
We have to be incredibly careful with developing bodies. Take the tetracyclines, for example. Doxycycline is a great drug, very useful, but all tetracyclines have a high affinity for calcium.
Which means what?
It means in a growing child, the drug can bind to the calcium in their developing bones and teeth. It can literally stain their permanent teeth gray or yellow and can even affect bone growth.
Wow. Okay, that's a serious side effect. And what about the fluoroquinolones?
In studies with young animals, they were shown to affect cartilage development and cause joint problems, so as a precaution, we avoid them in children. The bottom line is if your patient is 8 years old or pregnant, the drug of choice might be completely off the table. You have to go to your plan B or plan C immediately.
We also have to talk about the body's filter systems, the kidneys and the liver.
This is critical. Most of our antibiotics are cleared from the body by the kidneys. You pee them out. Imagine your body is a bathtub with the faucet on. That's the drug going in. And the drain open. That's the kidneys.
Okay, simple enough.
Now imagine the drain is clogged. The patient has kidney failure. If you keep the faucet running at full blast, what happens?
The tub overflowed.
The tub overflows. The drug builds up in the blood to toxic levels. For drugs like vancomycin or aminoglycosides, those high levels can destroy hearing permanently or shut down the kidneys completely, making the original problem even worse. So we have to renally adjust the dose. If the kidneys are only working at 50% capacity, we might have to cut the dose by 50%. It's a constant mathematical balancing act.
Speaking of chemistry, Section 4 had a part on drug interactions that I think everyone listening needs to hear. This isn't just hospital stuff. This affects anyone taking a pill.
Yeah.
Table 45.3 highlights multivalencations.
Oh, yeah. This is a classic pharmacy school pearl.
So break it down. What on earth is a multivalent chemation?
It sounds super technical, but it's just common stuff. Anything with a positive charge of +2 or more. We're talking calcium, magnesium, iron, zinc.
Things in multivitamins,
Yeah.
antacids, and dairy products like milk or yogurt.
Exactly. So picture this. A patient is taking ciprofloxacin fluoroquinolone for a nasty infection. At the same time, they decide to take their morning multivitamin with a big glass of milk.
What happens in the stomach?
It's a chemical disaster. The antibiotic molecules have these sites that just love to grab onto the calcium and iron. They stick together like magnets and form this big insoluble clump called a chelate.
So it basically forms a tiny rock.
It's effectively a rock. And your gut cannot absorb a rock. So the antibiotic just passes right through the digestive system and out the other end. It never even gets into the bloodstream.
So you think you're taking your medicine, but you're actually taking an expensive placebo.
You could fail therapy completely just because of your yogurt. That's why pharmacists tell you to separate them by at least 2 hours. Let the drug get absorbed first, then have your dairy or your vitamin.
That is wild. Another interaction that really stood out was metronidazole and alcohol.
The disulfiram-like reaction. This isn't just, oh, antibiotics might make you a little tipsy. This is a violent metabolic traffic jam. Your liver breaks down alcohol in a couple of steps. Metronidazole blocks one of those key steps, which leads to a massive buildup of a toxic chemical called acetaldehyde.
And that feels like?
The worst hangover of your life, multiplied by 10, happening instantly. We're talking violent vomiting, flushing, a racing heart, a feeling like you're going to die. It's incredibly unpleasant.
Note to self, do not mix those. And finally, on interactions, warfarin.
Warfarin is a blood thinner, and it is notoriously finicky. It relies on very specific liver enzymes to be metabolized properly. A lot of common antibiotics like sulfonamides or rifampin can mess with those
So you
enzymes.
throw the whole balance off.
You can accidentally thin the blood way, way too much. Suddenly a patient brushes their teeth and their gums won't stop bleeding, or they get a massive internal bruise from a tiny bump. If a patient is on warfarin, adding an antibiotic is a high-risk move. You have to monitor their clotting time like a hawk.
It really just emphasizes that you're not just throwing a chemical into a bucket, you're introducing a volatile new element into this incredibly complex ecosystem.
That is the art of it. You have to treat the whole patient, not just the bug in the petri dish.
So let's move on to the weaponry itself. Section 5 gets into the physics of how the drugs kill PK/PD, pharmacokinetics, and pharmacodynamics. And this is where the source differentiates between what I'm calling the hammer and the flood.
That's a great analogy. Let's start with the hammer. This is what we call concentration-dependent killing.
Which drugs are the hammers?
Aminoglycosides like gentamicin and the fluoroquinolones like Cipro. For these drugs, what matters is the peak. The higher the concentration spikes above what the bacteria can handle, the faster and more effective the kill. You want to hit them hard and fast with one big high dose to just overwhelm them.
One massive strike,
Yeah,
as opposed to...
time-dependent killing.
Yeah.
This is your flood. The beta-lactam so, penicillins, and cephalosporins work this way. For them, it doesn't really matter how high the concentration gets as long as it stays above a certain critical level. We call that the MIC, or minimum inhibitory concentration.
So a huge dose doesn't really help you more.
Not really. What matters is time. You need to keep the drug level above that MIC line for as much of the time between doses as possible. It's a siege, not a blitz. If the drug level drops too low, even for a short time, the bacteria start to repair their cell walls and recover.
So for a drug like penicillin, missing a dose or even just being 3 hours late is a much bigger strategic error than it would be with a hammer drug.
Absolutely. With time-dependent drugs, consistency is the weapon. You cannot let the siege lift, even for an hour.
We touched on this with the meningitis example, but I want to circle back to the idea of privileged sites. The body has bunkers.
It does. Fortified bunkers. The main ones are the central nervous system, the eye, and the prostate.
Why are they privileged?
Because they have evolved these amazing biological barriers to keep toxins out. The blood-brain barrier is the most famous one. It's this tight mesh of cells that wraps the blood vessels in the brain. It's great for keeping poisons in your blood from reaching your brain cells.
But unfortunately, it also keeps most antibiotics out.
It does. So if the bacteria manage to get inside that bunker, you have a huge problem. You need a bunker buster. You need a drug that is either really small or one that is lipophilic fat soluble so it can dissolve its way through the fatty cell membranes.
And if you use the wrong kind of drug,
If you use a big water-soluble drug, you can pump it into the patient's veins all day long, and almost none of it will ever reach the site of the infection in the brain.
the text even mentions that in extreme cases, you have to bypass the system entirely and instill the drug directly.
Yeah, that's an intraventricular injection. We literally have to drill a port into the skull or do a spinal tap and inject the antibiotic straight into the spinal fluid. Or, for a severe eye infection, inject it directly into the eyeball. It's invasive and risky, but if the systemic route fails, you have to go direct. You have to physically breach the bunker.
Wow. Okay, let's look at Section 6, Advanced Tactics, Combination Therapy. We talked about double-teaming Pseudomonas, but what are the other reasons to use 2 drugs instead of 1?
We always prefer to use one drug if we can. It's simpler, it's cheaper, it's less toxic. But there are 3 main scenarios where you break that rule. The first is simply to broaden the spectrum.
To cover all your bases when you're not sure what's going on.
Exactly. Or when you know you're dealing with a mixed infection, imagine a patient with a perforated appendix. The contents of their gut have just leaked into their abdomen.
That sounds bad.
It's very bad. And the gut is full of everything. Aerobic bacteria, anaerobic bacteria, gram-positives, gram-negatives. It's a whole ecosystem. No single drug can cover all of that perfectly. So you combine 2 or 3 drugs to create a net that's wide enough to catch everything.
Okay, so that's reason 1. What's reason 2?
Synergy. This is the mathematical miracle where 1 + 1 = 3.
Give me a concrete example of that.
The classic one is using a beta-lactam, like penicillin, plus an aminoglycoside, like gentamicin, to treat a serious enterococcus infection on a heart valve.
How do they help each other?
Well, the penicillin attacks the bacterial cell wall. It punches holes in the outer defenses. But on its own, it might not be enough to kill the bug quickly. However, Those holes that it creates allow the gentamicin to rush inside the cell, which it couldn't do easily on its own.
So the penicillin is breaking down the gate so the special forces can get in.
That's the perfect analogy. Once the gentamicin is inside, it gets to the ribosomes and shuts down the protein-making machinery. Neither drug could have killed the bug effectively alone, but together, they're lethal.
And the third reason to combine?
To prevent resistance. This is the absolute cornerstone of tuberculosis treatment. TB is a slow-growing, wily, ancient organism. If you hit it with just one drug, it is almost guaranteed to mutate and develop resistance to it during the long course of therapy.
It evolves in real time.
It does. So we hit it with 4 drugs at once, right from the start. Isoniazid, rifampin, pyrazinamide, ethambutol. The odds of a single bacterium spontaneously mutating to survive drug A and drug B and drug C and drug D all at the same instant are statistically 0. You cut off every possible escape route.
But there has to be a downside to just mixing drugs.
Oh, absolutely. It's called antagonism. This is when 1 + 1 = 0.
The drugs actually fight each other.
They can. The text mentions a specific mechanism called beta-lactamase induction. Certain drugs, like cefoxitin, act as a trigger. When they show up, they basically send a signal to the bacteria that says, hey, we're under attack, turn on your shields.
So they trip the alarm system for the bacteria.
They induce the bacteria to start producing huge amounts of beta-lactamase, which is an enzyme that chews up and destroys antibiotics. So if you give cefoxitin at the same time as a penicillin, the cefoxitin might trick the bacteria into producing the very enzyme that destroys the penicillin. You actually end up with a less effective treatment than if you had just used one drug alone.
So by giving drug A, you've accidentally told the enemy how to defeat drug B.
That's exactly what can happen. You have to know which drugs play nice together in the sandbox and which ones just sabotage the whole mission.
That is disturbingly complex. Okay, so we're nearing the end of the mission. Section 7. The aftermath. We've given the treatment. How do we know if we've won?
You have to watch the patient, not just the charts. This is a common mistake. A doctor can get focused on treating the numbers. Oh, the white count is still 11,000. But you need to look up. How does the patient feel? Is their fever gone? Is their appetite back? Are they sitting up in bed complaining about the hospital food?
If they look better, they usually are.
That's usually a great sign. Then we start looking for the switch from IV to oral therapy.
Right. Hospitals want patients taking pills and heading out the door.
It's safer for the patient. It lowers the risk of line infections from the IV catheter, and it's much, much cheaper.
Yeah.
But the criteria are strict. The patient has to be afebrile, so no fever for at least 8 to 24 hours. Their white count has to be trending down. And crucially, their gut has to be working.
Because if they're just going to throw it up, the pill is useless.
Right. If they have an ileus where the gut has stopped moving, or if they're vomiting, you can't switch. But if they're stable and eating and improving, getting them onto oral therapy is a huge victory.
But sometimes it doesn't work.
Yeah.
The patient doesn't get better. The fever hangs on. Why does therapy fail?
It's a detective story all over again. You have to go back and audit your entire strategy. First, was the diagnosis even right? Maybe it wasn't bacteria to begin with. Maybe it's a virus or a fungus or a non-infectious cause of fever like a lymphoma.
Or maybe we just picked the wrong weapon.
Or the wrong dose, or the wrong route, or maybe there's an absorption issue. The patient has short bowel syndrome, and they literally can't absorb the medicine from their gut. But there is one huge physical factor the text highlights that is absolutely critical: source control.
Right. The text had a graphic line. Pris is not pressurized blood.
It's graphic, but it's a vital concept. Antibiotics travel through the bloodstream. An abscess, which is a walled-off pocket of pus, has no blood supply in its core. It's just dead tissue and bacteria.
It's a fortress surrounded by a moat.
A perfect analogy. You can flood the entire body with antibiotics, but they will never penetrate the center of that abscess. You have to physically drain it. You have to stick a needle or a scalpel in there and let the pus out.
And the same goes for infected foreign bodies, right? Like a catheter or a surgical screw.
Yes. Bacteria love to grow on those non-living surfaces. They create something called a biofilm, which is like this slimy, protective shield. Antibiotics cannot get through that slime. If you don't physically remove the infected source, the chemical weapon will fail 100% of the time.
And finally, the biggest threat to success. Resistance.
This is the arms race. You have primary resistance, where the bug was just born tough, and then you have acquired resistance, where the bug actually learned to be tough during the treatment.
And the source is very clear on what drives this.
Overuse and misuse. Every single time we use an antibiotic, We are applying evolutionary pressure. We kill off all the weak, susceptible bacteria, and we leave the one or two naturally strong ones to survive and reproduce. We are, in effect, selectively breeding our own nightmares.
Which brings us to the end of this deep dive. We've gone from the fever trap through the minefield of drug interactions all the way into the bunkers of the brain. It's certainly changed how I'll look at a prescription pad from now on.
It should, and I hope it gives listeners a newfound respect for the complexity here. You know, when a doctor hesitates to give you an antibiotic for your sniffles, they aren't being stingy. They're not trying to save the hospital money.
They're playing the game.
They are playing that 4D chess game. They're thinking about the fever trap, about the possibility it's just a virus, about the risk of causing a C. diff infection, and about the long-term risk of creating a superbug. They're trying to protect you and the entire community.
I want to leave our listeners with a final thought, something the text alludes to but doesn't scream for the rooftops. We're inventing these weapons as fast as we can, but the bacteria are inventing shields just as fast.
Faster. In most cases. Their generation time is 20 minutes. Ours is 20 years. They have a huge evolutionary advantage.
So the definitive therapy of today, our best weapons, the vancomycins, the carbapenems, they could very well be obsolete in 10 years. We are always just one or two clever mutations away from running out of options on that menu we looked at.
Which is why this idea of antimicrobial stewardship isn't just a hospital policy. It's really about species survival. We have to protect the miracle drugs we have left because the pipeline for new ones is frighteningly dry.
On that rather cheerful note, thank you for listening, and go wash your hands.
Please do.
We'll see you on the next deep dive.